right, and now I'm going to pass it off to my colleague to introduce scenario one.
So the first case is there was, and this is based on a real case from a few years ago. When I say a few years ago, I mean about 20 or 30 years ago. So there's recently been a number of cases of patients dying after ingesting a relatively common over-the-counter medication. So on analysis, it's been found that someone has been tampering with the contents of the medication. And so it's not something that's specific to the company. It's something that they're trying to figure out the source of it, but it doesn't seem like that it's coming from the company itself. It's a Friday afternoon. And so what we're going to do is we're going to break you into 4 groups. And in those 4 groups, we're going to be asking you to take on one of 4 different roles in the crisis. So one role is going to be as the company CEO. And Michelle is going to be leading that one. The second role is going to be as a pharmacist and pharmacy owner, and Catherine's going to be leading that one. The third role is going to be that of a government official, and Sarah's going to be leading that one, and then I'm going to be leading the last one, which is going to be the role of the media. And so there's a bunch of questions that we're going to ask you in the small groups, and then we're going to come back together and sort of talk about what everyone's actions would have been in this particular case. And the goal is to figure out what would your communication strategy and leadership strategy be in this particular case.
How was it?
I think it was really hard. Well, I had the pharmacy group, so I think most people are not familiar with the role of being a business owner and having to think about things from that perspective.
I think we found that, and anyone from the group that I was in, please feel free to pop in. I thought that it was interesting because as a government official, you sort of need to take everyone into consideration.
Mm-hmm.
So we found ourselves kind of referring back to the different stakeholders a lot and thinking about how do we soften the message, how do we make sure that people don't get too angry about the situation, and also just maintain good relations from an economic perspective while still maintaining patient safety. And at the very end, we actually talked about who should be delivering the message from government, and we figured that a health official of some sort would be a trustworthy individual to relay the information and also make sure that everyone feels that things are okay and under control, or at least going to be in control in a couple months.
I was in the group with the CEO. Sorry, this is Jamal.
Hi.
Hey. I was in the group with the CEO that what to do right now in this chaotic situation. Like we are the owner of this company, and then there's multiple priorities on us. So we discussed that considering the public safety, considering the shareholder values and the reputation of the company, and we just have an initial report about one of our medication, we decided, the priority here to let people know either locally or mainly locally, maybe just a conference about what's going on. We don't have all the information, but we know one of our medication as the company may have an issue with it. So we're going to ask the public to be in the safe side, maybe just to stop medication, go for alternative till we see what's going on or figure out what's going on. And by doing this, we achieved the public safety. We were talking about, at least my idea, still, we are maintaining the reputation of the company and maintain the trust of public or the customer to this. And at the same time, give us a time to change this chaotic situation to a more less complex, or we'll go there to a complex issue. So as CEO, I think we have the manpower to break it down and delegate tasks to see what's going on. And again, as we promised in the conference, we will let the people know with any update.
Yeah, that's fabulous, Jamal. Great work. And Denise, do you want to just anything to add? Because it was a fun role.
Yes. Someone else was mentioning that they thought the health people should be making that announcement, but we think the CEO should be there with them because this is their company. They have a major say in this. We want the CEO part of that announcement to the community. We feel that we need to be honest with the people. We need to gather the information, and we know that something's happening. We're not sure what's happening, but public safety is paramount, and we want to find out what's going on, and when we know more information, we're going to let people know.
Yeah, it was a great discussion. Denise and Jamal basically decided, you know what, we're going to do this immediately on the Friday night. we're going to go completely public. I tried to convince them otherwise, but I couldn't do it. Completely go public, take everything off the shelf. My goodness, their company might be gone, except if it's still there, at least people are going to trust them.
Take the first flight out.
So we were the media group, and sort of the discussion that we had is that the media sort of position is that we agreed this was certainly a chaotic situation, and very much we were like we assumed that the company would want to say something to people, and so when we came to you, the hope would be so we're going to come to you, we're going to report this. Do you want to say anything? Do you want to get ahead of it? And we thought the same thing for the health officials, because we figured that the messaging would want to get out there, and so we thought that we'd come and ask and say, we're putting it out there, so come now, right? Now's the time to get your message out. So can you do that?
And from the pharmacy group point of view, this is obviously a chaos situation when a patient dies who has purchased medication from your store. So it's a highly scary, anxiety-provoking situation. So it's really hard then to, as a leader in that situation, to pivot the focus of attention away from how this threatens you legally and your business to let's support the staff, let's support the patients, and see what else we can do for the community. And understanding that every day that goes by going forward is going to be hard, but there will be more information. So then hopefully there will be more clarity in what to do. So in the interest of time, we should move on to our next case, which is a bit different. This is a multiplayer case where each group, we will have different roles being played by within the same group. So it would take us a couple of minutes to go through different roles. I think it might be helpful to stay in the large group for this part so that we're all up to date on whose job is what, and then go from there.
Sounds great. So I have the slides up here. Michelle, do you want to read them or?
Sure. Why don't I just read them while people are looking at it? Mm-hmm. So this is a medium-sized community hospital called General Hospital. And yes, I did used to watch this in the 80s. The general medical unit on the second floor is designated to be non-COVID. So all of you working in the hospitals are just thinking about, okay, so we got a non-COVID unit. All patients have to have a negative swab prior to admission. But unfortunately, you have patient A. Patient A was admitted for syncope, had a negative swab. However, now they're exhibiting classic signs of COVID-19, including generalized aches, cough, fever, and they're hypoxic, really strangely hypoxic on room air. And so this, so we're now on Thursday. So Wednesday evening, people had noticed this and a swab was sent. It's now Thursday morning, and Employee Health Services has some concerns and says, I think we need to have a meeting. So you all come up to the second floor. There's an education room there, and we're going to have a meeting. In your groups, you only need the first 3 or 4 of the people that are here. There's 6 listed. If there's only 3, 4, or 5 people in your group, you only need the number that you have, okay? The first 3 or 4 are the most important. So just really quickly, we need someone to be in each group, the hospital administrative director for all the inpatient units. Second, the general internist, a physician for that medical unit. Third, a person that plays both the employee health services director as well as the infection prevention and control director. And then fourth, the nurse manager for that medical unit. If you have more people, it's great. We could add on the MAC chair and the nursing union steward, but I don't think we'll need it for today. So we're going to break you up into those groups. We'll tell you a little bit about those roles when we get into the groups, and then we'll have you play the role. And Catherine, if you can just tell us how long, and we're not going to come back for a debrief per se. We'll actually do it as we go in the small group.
So it's 8:30 right now. I think we could probably go for 20 minutes on this case, and then we'll show these slides again in the small group. So that was a very difficult case, Michelle.
Oh, thank you. I love it. Liam is the one that's doing this all the time. So he's on these calls with the hospital. As you may have heard, there may or may not have been an outbreak at a hospital I work at, as a lot of hospitals have. And so I wasn't part of all those calls. So I'm sure he was snickering away when he read this, thinking about the insight of what actually happens when this happens in a hospital. I'm interested in your insight, Eileen, in terms of the communication, right? The getting together, you're on mute, Eileen, the getting together and having that first good discussion, and then, how you leave the room with communication.
So a lot of it was, there was a lot of discussion around how do you, so what do we communicate, to whom do we communicate it? And so, there was a lot of discussion about this information is going to be going out to staff, and usually in advance of that, a lot of the leadership gets briefed in advance so that when you get questions from your staff, because you invariably do. So when the memo went out that there was an outbreak, we got, I think all of us got a couple of dozen questions from staff saying, what does this mean? How's it going to work? What's happening to the staff? Are the staff okay? Because there was a lot of concern also about the staff on the floor. Is everyone okay? Are we still going to have a COVID unit? And of course, it happens a couple of days after a large number of patients had been transferred in from the community as well. So a lot of it was, interestingly, there was very little disagreement, fortunately, in the meeting, but I could see how that might be problematic. But certainly for us, there was a lot of agreement between sort of the leadership and IPAC. And so I think it was a very mixed model. We had expert input from our infection control practitioners, our ID physicians. We had some media relations people on the call as well to say, how are we going to market this? How are we going to tell this story to the community? Not in the interest of hiding anything, but how are we going to communicate it out to the public? And also, how are we going to communicate it internally to our own staff? And then what are we going to do for the staff? And so the staff was, we universally tested everybody up on the floor. We isolated everybody. Anybody who was symptomatic or was positive got sent home. And then, of course, you then have to look at the HR staffing issues. So we've now sent home 8 staff. That's not a small percentage of your nursing staff on a ward. How are you now going to backfill that to cover your nursing staff? So those were a lot of the conversations that were happening. And of course, it happened on some afternoon as everyone's trying to make their way out the door. And you're kind of like, well, I guess not only are we meeting today, but we're meeting tomorrow on the weekend because we got to sort everything out. And interestingly, it was a very similar discussion that we had when we heard that a nursing home was going to be, or retirement home was going to be decanting to the hospital groups. So it's very germane. So.
And the only thing that I'd love to add, if you don't mind, Catherine, is I'm sure some people here have heard about Dr. Bonnie Henry. And so she is the medical officer of health in British Columbia. She was the medical officer for Toronto during SARS back in 2003. And 2002. And so if anybody hasn't seen the video of the press conference that she had where she declared the first outbreak in a long-term care, it's worth going and looking at that video. And so for those of you who are aware, I don't need to say much, and those of you who aren't, she's probably looked at as the best leader in the world right now in terms of how she's leading her area around COVID. Very, very practical, quiet, sweet, and really well prepared for this. She has always been a bit of my hero. I know her well, and so just so you know, if you ever want to look it up, she in fact did have tears when she announced the very first outbreak in the long-term care. They sort of called her on it, and she said, yes, this hurts me because I thought I could prevent this essentially. But what she did immediately, but thank goodness the government listened to her and allowed her to, is they took over the staffing for every long-term care in the province of BC, and that was around the 12th or so of March. So every single place, nobody could work in two places. Everybody was given full-time hours if they didn't have full-time hours, so that they wouldn't have to work in more than one place. And they did not have another outbreak, although they did have many deaths at that one institution, including somebody who's related to our family. But I really believe they handled it very, very well. So that's all I need to say. It's wonderful. And Aleem has put up a link to the New York article, the New York Times article about her. It's pretty amazing. Thanks.
That's fantastic. It's actually kind of, it echoes the way that the Tylenol crisis was handled as well. It was, the timing of it and the scale of it. At the beginning, I think it's, now looking back, all of us can say, yeah, of course, that's the right thing to do. But in the moment, to be able to make that kind of decision and be able to persuade others that that is the right thing to do, it's really extraordinary. We in Kitchener-Waterloo actually had very similar situations in March, April, several incidences. Certainly, we've learned our lessons. We can see from the receiving end of things, as physicians, where the communication had been fantastic and frequent and honest and clear, and then in the incidences where they're not, and there's lack of it, or if there's barriers in accessing that information that immediately can cause a lot of anxiety and complaints and negative attitudes. So it is certainly looking back, I agree with all the principles that we've put together for this evening. Does any of the participants want to say a word or two about how their experiences were the last case?
I had the hospital administrative director role, and I found that was very challenging because there were a lot of stakeholders that you have to engage, and a lot of different groups that you need to communicate with, as well as potentially people outside of your institution, including media. So being able to tailor your message and be able to give the right amount and the right type of information to each group is a challenge.
Yeah, absolutely. So when we talked about as a strategy, we want to think in the ways, in the structure of who to communicate to, what to say, how to say it, in what medium. For that particular role, you really have to be capturing every person, from the patient's family to the media to your leadership team. And in the end, there's a role that we didn't play as a group because we had 4 people, but there's the union rep in there as well, that sometimes we in the moment of crisis don't always think about. Anyone else has any comments, or any comments about what we talked about this evening? Whether it might be applicable to your day-to-day challenges, or how you can see a situation when you get thrown into a situation where you didn't really sign up for, but boom, you're in that situation and you happen to be the medical director of such, or the physician lead in this clinic or whatever. How do you feel about dealing with that sort of situation now, knowing what you know?
I think it's a great, sorry, Jamal. I think it's a great way to look at, especially with chaotic issues or throwing you in a new rule, take it step by step. I think looking at it from my clinical practice, I think I can apply that for multiple things. Situation like we talk about infection here, from a physician to taking an administrative role, run that side or anything, or from any, again, this is just another side, from practical point of view, looking at any issues in your practice, if it is chaotic or complex, you just break it down to a simple way. Just make it, take it slowly, and I'm sure you're gonna get it solved.
Yeah, it's nice to have an approach. So you could, if you can't diagnose the situation, it's hard to manage it, right? So the medication poisoning case, the outbreak case. So they're very different problems, but the diagnosis is the same. It's chaos. So the way to manage chaos is control and command, up until when that chaos is no longer chaos. So I'm personally feeling, as we are right now, things are kind of moving from chaos, which was March, April, early April, into perhaps a complex situation where we're having a lot more conversations. We have some more time to weigh pros and cons and allow some time to allow the solutions to each individual problem to kind of emerge. And hopefully at some point, once we know more about the disease, it becomes more of a complicated situation. And hopefully one day, who knows, it might become a simple thing. Other comments? It's 9:04, so thank you very much for both the panelists and all the participants for staying with us and participating and contributing to our conversation.